Namaste. Myself, Dr. Raut, consultant physician and director, Sarvajna Multispeciality Hospital, Pune. I am going to present you a case newly diagnosed type 2 diabetes with high baseline HbA1c level. Mr. AB, 45-year-old, with newly diagnosed with type 2 diabetes mellitus, visited clinic 6 months back with multiple risk factors like obesity, hypertension, hyperlipidemia. He was initiated with metformin with advice for lifestyle and diet modification. Recently, he visited again as part of routine checkup. His laboratory workup showed following reports. Laboratory measurements: HbA1c 8.5%, estimated GFR 80 ml per minute per 1.73 meter square, LDL 80 mg percent, HDL 38 mg percent, and triglycerides 200 mg percent. Medications: metformin 1000 mg BD, lisinopril 40 mg OD, metoprolol ER extended release 100 mg OD, atorvastatin 40 mg OD, aspirin 75 mg OD. On physical examination, his body mass index was 31 kg per meter square. Blood pressure was 120 by 70 millimeters of mercury, and heart rate was 78 beats per minute. Evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complications in type 2 diabetes. UK pediatrics demonstrated a legacy effect of early intensive therapy because the difference in the CV event rate 10 years post-trial was apparent even though no difference in HbA1c levels between the intensive and conventional therapy. When metformin is not suitable and empagliflozin or linagliptin is being considered as an alternative first-line treatment, initial combination therapy may be considered to achieve target more quickly, particularly in patients with high baseline HbA1c level. Early combination therapy in type 2 diabetes makes clinical sense for several reasons. First, a meta-analysis demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target of HbA1c less than 7% compared with metformin monotherapy. For patients with HbA1c more than 1.5% above the goal at diagnosis, EDA and EASD guidelines recommend first-line treatment with the dual combination and SGLT2 inhibitor as the first post-metformin treatment in patients with established CVD, CHF, or CKD. EMPA and LENA combination with complementary mechanism and pleiotropic benefits may be a suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease or high-risk established heart failure or CKD due to the tolerability of the combination in addition to the potential benefits of empagliflozin on CV and renal outcomes, and no increased risk of heart failure with either agent. According to study, early achievement of HbA1c goal less than 7% with EMPA and LENA could reach target HbA1c at 12 weeks compared to monotherapies. HbA1c decrements by EMPA-LENA 25 and 5 mg combination has demonstrated 1.81% HbA1c reduction at HbA1c baseline more than 8.5% at 24 weeks in metformin treated groups. The benefits on glycemic control were maintained at week 52 in metformin treated groups, and a higher percentage of patients achieving HbA1c less than 7% were reported for combinations. The combination offers a suitable component in strategy to achieve target HbA1c without increased risk of hypoglycemia and weight gain with improvement in overall lipid profile. A reduction in the incidence of genital infections associated with SGLT2 inhibitors has been reported when a DPP4 inhibitor is added, perhaps because of a better glucose control through other possible mechanisms remain to be investigated. So, in summary, EMPA-LENA combination provides a robust HbA1c reduction and 2 to 4 times higher odds of patients reaching the goal of HbA1c compared to individual agent with low hypoglycemic risk. Thank you.